Today we are wading into the world of antidiuretics, drugs and hormones that act as the master control switch for how much water your body retains or expels. This is fundamental physiology, and if you've ever wondered why certain medications have strange side effects or why alcohol makes you so dehydrated, this deep dive's for you.
We're working through some dense, highly technical source material provided by our listener. It covers the pharmacology of powerful hormonal peptides and the intricate systems they control.
Right.
Our mission is to extract the essential insights on how we manage every drop of water, focusing primarily on arginine vasopressin, or AVP, and the custom-built drugs that mimic or block its action.
Think of this as a shortcut to truly understanding the kidney's advanced plumbing system.
That's a good way to put it.
That's the mission. We're going from the molecule made in the brain all the way to the medicine used in the ICU. But first, let's get specific. When we say antidiuretics, we need to use the more precise term highlighted in our source material,
Yes.
which is antiacoretics.
That distinction is crucial. I mean, it sounds like splitting hairs, but it's not.
How so?
An antiacoretic is a substance that inhibits water excretion without significantly affecting salt excretion. A standard diuretic often flushes both salt and water.
Okay, so it's a targeted action.
Very targeted. AVP, the primary natural antiacoretic, is designed to save pure water to fix the concentration. Gradient saving volume is, believe it or not, secondary.
And that's what makes it so powerful.
Exactly. Clinically, their primary use is reducing excessive urine volume, known as polyuria, especially in a condition called diabetes insipidus, or DI.
And to give you a quick roadmap of what we pulled from the sources, we're starting with the foundational physiology, how this hormone is made and released.
The very beginning.
Then we dive deep into the cellular mechanics of the kidney. We'll look at AVP's surprising systemic roles outside the kidney in clotting and blood pressure.
Which are fascinating.
And finally, we move to the pharmacy shelf, the specific analogs, the antagonists, and some truly mind-bending therapeutic paradoxes.
Okay, let's get into it.
Okay, let's unpack this tiny powerhouse, arginine vasopressin, or AVP. To understand its profound effect, we have to start with its structure. What is this hormone chemically?
It's an 8-arginine nonapeptide.
Okay, let's unpack that.
Right. It means it's a short chain made up of only 9 amino acids, with arginine holding the critical 8th position.
So it's tiny.
It's tiny, but that structure is actually very similar to oxytocin, which is key to understanding its cross-reactivity in certain tissues later on.
I see.
So its small size really belies its dual identity. It is both the ultimate water conserver, the antidiuretic, and at higher doses, a powerful pressor agent.
Which is where the vasopressin part of the name comes from.
Precisely.
It's fascinating that such a powerful systemic signal starts deep within the brain. Talk us through the synthesis and transport. It's not a simple one-step process, is it?
Not at all. The synthesis is highly specialized. ADP is made in the cell bodies of specific neurons located in the hypothalamus, specifically the supraoptic and paraventricular nuclei.
But it doesn't start out as AVP.
No, it doesn't. It's first created as a much larger, inactive precursor peptide.
So it's a pro-hormone. How does it get to where it needs to be released?
It needs a chaperone. While inside the cell, this large precursor binds with a crucial binding protein called neurophysin.
Neurophysin, okay.
This neurophysin hormone complex is then packaged into tiny secretory vesicles and transported down the long axons of those neurons.
And these axons go a long way.
They extend all the way down into the posterior pituitary gland, or neurohypophysis. So the posterior pituitary is essentially just a storage depot for these nerve endings.
So it's not making anything there, just holding it.
Just holding it. AVP is stored there and released directly into the systemic circulation upon receiving the appropriate nerve signal. It is an extremely elegant delivery system designed for rapid deployment.
It's like the brain packaging a signal in a secure vessel and sending it down a dedicated fiber optic line for quick deployment into the blood when needed.
That's a perfect analogy.
Our sources also mention a slight structural footnote regarding other mammals.
Correct. It's a small point, but interesting. While human ADH uses arginine, there's another version, 8-lysine vasopressin, or lipressin.
And that's found where?
That's the analog found in swine. This version has also been synthetically prepared for clinical use, although we mostly rely on the arginine-based synthetic derivatives today due to superior potency and duration.
So we have AVP stored and waiting in the posterior pituitary. What are the signals, the tripwires, that tell the brain, release the water-saving hormone immediately?
The body has 2 master controls, constantly monitoring hydration, but one is far, far more sensitive and primary.
Let's start with that primary trigger.
That is plasma osmolarity, the concentration of solutes in your blood.
The saltiness,
The
essentially.
saltiness, exactly. Specialized osmoreceptors in the hypothalamus are incredibly sensitive to tiny increases in plasma concentration.
How sensitive we're talking.
If you get even slightly dehydrated, or if you consume too much salt, the osmolarity rises. These receptors immediately fire, signaling for ADH release. This mechanism is so sensitive that a change of as little as 1% in plasma osmolarity can trigger AVP release.
1%, that's a razor-thin margin.
It is. It's basically the body testing the salinity of the internal environment, and if it gets too concentrated, it hits the emergency save water button.
Okay, so that's the main highly sensitive trigger. What's the secondary less sensitive trigger?
That's the volume status, which is monitored by volume receptors.
And where are those?
These are strategically placed in low-pressure, high-volume regions, the left atrium, the ventricles, and the pulmonary veins.
So they're measuring stretch.
They're measuring the stretch of the vessels, yes. If your extracellular fluid volume drops significantly, say more than 5 to 10%, like from a hemorrhage or profound dehydration, the pressure drops, the stretch decreases, and the volume receptors signal for a massive AVP release to restore blood volume.
So osmoreceptors are for fine-tuning, and volume receptors are for emergencies.
A good way to think of it. The osmoreceptors are the nuanced daily managers. The volume receptors are the emergency system for true volume depletion.
The sources mention a fantastic piece of physiological foresight regarding the gut. It's almost an anticipatory mechanism.
It's the body's early warning system. It's really clever. We also have osmoreceptors in the hepatic portal system.
The blood supply from the gut to the liver.
Exactly. So when you ingest a large load of salt, a really heavy salty meal, these receptors detect the change in concentration before that salt has even been fully absorbed and circulated throughout the entire body to raise general plasma osmolarity.
So it gets a head start.
A huge head start. They can trigger AVP release immediately, getting a jump on water conservation, sometimes hours before true systemic dehydration would otherwise set in. It's a mechanism designed to preempt the osmotic crisis before it fully develops.
That's elegant engineering. The body preemptively conserving water based on what just went into the stomach.
So the key takeaway here is that AVP release is fundamentally driven by high plasma concentration or low overall blood volume.
Right, but it's not that simple. If we connect this to the bigger picture, AVP isn't working in isolation.
Of course not.
Its release is a highly integrated process, finely tuned and modulated by dozens of other hormones, neurotransmitters, and drugs. It's a control knob, not just a simple on-off switch.
So we have chemicals that effectively step on the gas pedal, significantly enhancing AVP's release or action. Which are the most important modulators in that category?
Well, one of the most critical is angiotensin II,
Which is all about blood pressure.
a central player in the body's renin-angiotensin-aldosterone system, or RAAS, which controls blood pressure. Angiotensin II strongly enhances ADP release, ensuring that if you're trying to raise blood pressure via RAS, you're also conserving water volume to help.
Makes sense. The two go hand in hand. They do. Other enhancers include prostaglandins, or PGs, histamine, neuropeptide Y, and acetylcholine. We also see a complex effect with opioids.
How so?
High-dose morphine can inhibit ADH release, but surprisingly, low doses actually enhance it, suggesting distinct receptor interactions at different concentrations.
It shows how intertwined the regulation of pressure and volume truly is. If those are the boosters, what applies the brakes? What chemicals inhibit AVP release?
The inhibitors include GABA, the primary inhibitory neurotransmitter in the CNS, atrial natriuretic peptide, or ANP.
ANP, that's released by the heart to lower volume.
Yes, explicitly released by the heart to lower volume and pressure, so it's a direct anti-AVP agent. Then you have phenytoin and glucocorticoids. Nicotine and sympathomimetic amines are also listed as inhibitors.
Okay, now let's discuss the common consequence of ADH inhibition that almost everyone has experienced: ethanol.
Right.
The rapid, excessive urination after drinking is a direct result of this hormonal disruption. Mechanistically, how precisely does alcohol disrupt the hypothalamic signaling?
Ethanol acts directly on those hypothalamic nuclei responsible for AVP synthesis and release.
It just shuts them down.
It inhibits the release of ADH. And ADH is the hormone specifically designed to put the brakes on water loss. So, without that signal, the kidney cease receiving the instruction to save water.
And the floodgates open.
The floodgates open. Instead of producing concentrated urine, they produce a large volume of very dilute urine, leading to rapid diuresis.
And this isn't just an inconvenience, it's the root of the next morning's misery.
Absolutely. The subsequent profound water loss leads to dehydration, which upsets the delicate electrolyte balance, including sodium and potassium levels.
And that's the hangover.
That severe dehydration is a major contributor to the headache, the fatigue, and the general malaise associated with a hangover. The body is essentially overcompensating for the lack of AVP signal, flushing water that it desperately needs to maintain homeostasis. It is a powerful, real-world example of what happens when the master water switch is temporarily flipped to the off position.
So AVP has been synthesized, transported, released, and is now circulating. It's a nonapeptide, a tiny key. Now, where are the locks, and what doors do they open in the kidney? It interacts with a highly specific system of receptors.
That's right. It operates via the V system, 3 main subtypes of G protein-coupled membrane receptors. And understanding the system is crucial because modern drug therapy is all about selectively targeting V1 versus V2.
Let's focus first on the receptor that mediates the entire antiachoretic effect. V2.
V2 receptors are almost exclusively located on the principal cells of the collecting ducts in the kidney.
So this is the front line.
These are the front lines of water conservation. When AVP binds to V2, it activates the classic CAMP pathway, the cyclic AMP system. Think of this as the main water-saving signal cascade.
And these are very sensitive.
Exquisitely sensitive. They're activated at the lowest circulating concentrations of AVP, meaning they respond first to subtle changes in body hydration.
And V2 does a double duty, correct? It affects both the collecting duct and the loop of Henle.
Exactly. Beyond the collecting duct, V2 receptor activation also works upstream by activating the Na plus K plus 2Cl cotransporter.
We'll call it NKCCC.
NKCC2, yes. In the thick ascending limb cells of the loop of Henle, this massive pump is essential for driving salt out of the tubule and building the crucial high solute environment, the medullary hypertonicity that water reabsorption relies upon.
Okay. Now let's turn to the V1 receptors, which seem to handle the non-renal or systemic effects. Why are they subdivided?
V1 receptors are divided into V1A and V1B, and they use a completely different internal signaling pathway.
Not PMP.
No. They mediate actions through the phospholipase CIP3DAG pathway. This pathway is far more dedicated to muscle contraction and calcium mobilization compared to the CAMP pathway of V2.
Let's trace V1A. What are its functions?
V1A receptors are highly widespread, found on vascular smooth muscle, visceral smooth muscle in the gut, the liver, and the brain.
Yeah, they cause contraction.
Since they are linked to the IP3 system, their activation results in contraction. This means widespread vasoconstriction, which increases peripheral resistance and, potentially, blood pressure. They also mediate glycogenolysis in the liver and platelet aggregation, critical actions we will explore later.
And V1B.
V1B receptors are more localized. You find them in the anterior pituitary, the brain, and the pancreas. They also utilize the phospholipase C pathway, and their primary known function is promoting the release of ACTH,
The stress hormone.
which links AVP to the broader endocrine stress response system. So, to summarize, V2 manages water, V1A manages blood vessel squeeze, and V1B manages stress hormone release.
What's fascinating here is the sheer speed of the antiachoretic effect. The kidney doesn't wait to synthesize new water machinery.
No, it mobilizes existing infrastructure. We're talking about 2 stages of action, but the rapid stage is immediate and dramatic.
How fast is the turn-on process at the cellular level?
It's instantaneous. When AVP binds to the V2 receptor, the resultant CAM-E signal activates protein kinase A, or PKA.
And PKA is the trigger.
PKA is the critical trigger. It sets off the exocytosis and translocation of aquaporin-2 water channels, AQP2.
And these channels aren't built on demand.
No, they are pre-assembled and stored inside the cell in packages called water channel containing vesicles, or WCVs.
So to visualize this, it's like AVP is a foreman telling the kidney cells, stop waiting and put up the water gates right now.
Exactly. That is a perfect analogy. The cell suddenly fuses those prefabricated water channel doors directly into the apical membrane of the collecting duct cells.
And once they're there,
Once these AQP2 channels are inserted, water which had previously been blocked by the impermeable membrane rushes out, driven by that medullary hypertonicity we discussed. This is the main antidiuresis action, and it happens in minutes.
that's the put them there phase. Is there a keep them there phase?
Yes. AVP also inhibits the endocytotic removal of those AQP2 channels.
The cleanup crew.
Right. Normally, the cell would retrieve the channels to clean house, but AVP tells the cell to keep the water gates open, ensuring sustained conservation until the signal concentration drops.
What other key transporters are mobilized in this rapid phase?
Two others are vital for achieving maximum water reabsorption. First, we see the activation and translocation of the vasopressin-regulated urea transporter, VRUT,
VRUT.
at the apical membrane of collecting ducts deep in the inner medulla. This action enhances urea recycling, which is crucial for maximizing the high concentration gradient necessary to pull water out. Without VRUT, you lose your osmotic pulling power.
And second, going back to the Luke of Henle.
The fourth rapid action is the translocation of that massive salt pump, the NKCC2 cotransporter, to the luminal membrane in the thick ascending limb.
Yeah, you're boosting the salt pump.
An immediate boost in NKCC2 activity. This increases the reabsorption of sodium, potassium, and chloride, which further intensifies the medullary hypertonicity. All these rapid actions work together to make the kidney a water retention machine.
Simultaneously, while V2 is handling the water channels, the V1A receptor is playing a critical synergistic role right there within the kidney's medulla.
It is.
We established V1A causes vasoconstriction, but why is constricting blood vessels inside the kidney helpful for water retention? It seems like it would reduce kidney function.
It's counterintuitive, I know, but highly effective. The V1A receptor mediates vasoconstriction of the vasa recta, the tiny blood vessels that supply the highly concentrated inner medulla.
Why do that?
If blood flow is too high through the medulla, the passing blood quickly washes out the solutes, the salt and urea, that the NKCC2 pumps and VRUTs have worked so hard to concentrate there.
Ah, so it's a preservation mechanism.
Precisely. By slowing the blood flow, by reducing the washout, AVP ensures that the high osmolarity in the inner medulla is maintained.
And you need that gradient.
That preserved high concentration gradient is the engine that drives the osmotic movement of water out of the collecting ducts through those newly installed AQP2 channels. So V2 makes the channels permeable, and V1A preserves the necessary osmotic environment for them to work.
So the rapid response is mobilization of pre-existing machinery. But the source material notes that AVP also dictates long-term structural changes. What are those sustained effects?
For long-term antiaquaretic status, the body must transition from mobilization to synthesis. AVP mediates increased gene expression.
So it's telling the cell to make more parts.
The actual creation and synthesis of both aquaporin-2 channels and the NKCC2 cotransporter in TL cells. This sustained production ensures that the necessary infrastructure is constantly replenished and ready for use, allowing the body to maintain water balance during conditions of chronic stress or prolonged dehydration.
So the immediate effect is a cellular movement. The long-term effect is a molecular construction project.
That's a great way to summarize it.
The kidney job is clear: conserve water. But let's look outside the kidney. The V1 receptors, especially V1A, give AVP a massive systemic impact, notably on the cardiovascular system.
AVP is indeed an extremely potent vasoconstrictor. Perhaps one of the most powerful natural constrictors we have. This action, mediated by V1A, causes widespread constriction of blood vessels and increases peripheral resistance. However, the effect on systemic blood pressure is complex and dose-dependent.
How so?
At lower physiological doses, the normal levels released to manage daily hydration, the V1A-mediated vasoconstriction tends to be counterbalanced by other compensatory mechanisms, often including a decrease in cardiac output.
So blood pressure doesn't really change?
Net blood pressure may not change significantly, no. However, administer AVP at high pharmacological doses, and you absolutely see frank vasopressin-induced hypertension.
Where is that high-dose vasoconstrictive power most clinically relevant?
It's crucial in specific states of shock, particularly septic or hemorrhagic shock, where the patient experiences profound vasodilation and a catastrophic loss of vascular tone.
The blood vessels are too wide open.
Exactly. In these distributive shock scenarios, AVP can be highly effective as a pressor agent to restore vascular resistance and stabilize blood pressure, often when traditional agents like norepinephrine are failing.
That said, using such a powerful vasoconstrictor must come with risks for patients with existing heart problems.
Absolutely. The sources warn that prolonged exposure to high AVP concentrations can lead to vascular smooth muscle hypertrophy.
A thickening of the vessel walls.
Yes. Furthermore, the V1A-mediated vasoconstriction can be unmasked, meaning its pressor effect becomes dominant, if AVP is administered while simultaneously blocking the V2 receptor.
Why is that?
Since V2 activity has some minor dependent mechanisms that can contribute to lowering BP, blocking V2 allows the V1 effect to dominate the pressure response. This complex interplay means careful consideration is necessary in patients with pre-existing cardiovascular issues.
Beyond blood vessels, AVP acts on other involuntary muscles, right? Where do we see its effect on the gastrointestinal tract?
AVP activates smooth muscle in the GI tract, increasing peristalsis, particularly in the large bowel.
So it gets things moving.
It does. This often leads to increased gut motility, resulting in the evacuation of bowels and the expulsion of gases. This V1-mediated action is why vasopressin or its analogs are sometimes used clinically, though less frequently now, to treat issues like post-operative ileus.
Which is a temporary paralysis of the gut after surgery.
Correct.
And the uterine connection, given its structural twin, is oxytocin.
Structurally, AVP and oxytocin are nearly identical, differing only by 2 amino acids. So AVP can contract the uterus by acting on oxytocin receptors.
But it's not a primary effect.
No, this effect is largely non-selective and only clinically significant when the uterus is highly sensitive to oxytocin, such as during full-term pregnancy. It's not a therapeutic target, but it shows the shared ancestry of these two neurohormones.
Okay, now let's address that incredible, surprising connection between a water hormone and the clotting cascade. How does AVP become a blood clotting agent?
This is a critical V2-mediated action, completely separate from the kidney. It's really amazing. We find V2 receptors not just on the kidney-collecting ducts, but also on the endothelial cells lining blood vessels.
The inner lining of the vessels themselves.
Right. And when AVP, or a selective V2 agonist, activates these receptors, it triggers the release of 2 crucial coagulation factors that are stored within the endothelium.
What are they?
Coagulation factor 8 and von Willebrand's factor, or VWF.
So it's not initiating the cascade from scratch, it's mobilizing reserves that are already there.
Exactly. It's a key mechanism we use therapeutically. By increasing circulating levels of these factors, especially VWF, we can help improve platelet adhesion and plug formation.
Which is why
Certain AVP analogs are used as a non-transfusion treatment for patients with conditions like hemophilia A or von Willebrand's disease.
Since AVP is synthesized in the hypothalamus, deep in the brain, does administering it externally affect the brain?
That's a good question, and the answer is usually no. Exogenously administered AVP, if you give it intravenously, for instance, does not penetrate the tight blood-brain barrier effectively.
So its clinical effects are
Almost entirely peripheral, yes.
But within the CNS itself, it must have a natural role as a neurotransmitter, given its synthesis location.
Absolutely. AVP is recognized as a key peptide neurotransmitter and neuromodulator in numerous brain areas and the spinal cord. It is deeply implicated in regulating essential homeostatic functions like body temperature and systemic circulation.
And more than that.
Much more. Activation of the V1b receptor links AVP to the ACTH release and the stress axis. And most fascinatingly, AVP is strongly implicated in complex cognitive functions, including regulation of learning, memory tasks, and social cognition.
So the very hormone that dictates whether you conserve water also helps dictate how you remember the world.
It's one and the same.
We've established that AVP is powerful but non-selective. It hits V1 and V2. In the clinic, doctors often need to be highly targeted.
Right. You don't want to squeeze blood vessels when all you want to do is save water.
Here's where pharmaceutical analogs come into play, built to focus on one receptor over the other.
The quintessential example of targeted action is desmopressin, or DDAVP. Scientists engineered the synthetic nonapeptide specifically to be a selective V2 agonist.
What does that enhanced selectivity mean practically for the patient?
It dramatically reduces the unwanted V1-mediated side effects, specifically the powerful vasoconstriction that can raise blood pressure.
And it lasts longer.
Much longer. Desmopressin provides about 12 times more antidiuretic activity than native AVP, and critically has a much longer duration of action, typically 8 to 12 hours. This makes it far more practical for managing chronic conditions compared to the short half-life of AVP.
So what are the primary clinical scenarios where this V2 selectivity makes desmopressin the drug of choice?
First and foremost is diabetes insipidus of pituitary origin, known as neurogenic DI.
This is the condition where the brain simply doesn't produce enough AVP.
Correct. Since the kidney receptors, the V2 receptors, are intact and working, desmopressin works perfectly to substitute for the missing hormone.
But it's key to distinguish this from the other type.
We have to emphasize that it is ineffective in renal DI where the kidney itself is faulty and unresponsive to ADH. That's a major diagnostic and therapeutic distinction.
We also talked about that incredible V2 link to clotting factor release.
Yes. Desmopressin is used preoperatively or during bleeding episodes in patients with mild hemophilia A and von Willebrand's disease.
How does that work again?
By activating those V2 receptors on the vascular endothelium, it boosts the release of factor VIII and VWF, offering a significant improvement in clotting ability without the need for plasma component transfusions.
Beyond these critical uses, what are the more common applications?
It's routinely used for managing primary nocturnal enuresis bedwetting in children and nocturia, which is excessive nighttime urination in adults, restoring a normal sleep pattern.
I see.
It's also used diagnostically in the renal concentration test to determine the maximum concentration capacity of the kidney.
And the delivery method.
Intranasal administration is often preferred due to its higher bioavailability and tendency to cause fewer systemic side effects compared to subcutaneous or intravenous dosing, though oral tablets are also available.
Moving to the other major analogs, let's look at a drug that leverages the V1 vasoconstrictive power, terlipressin.
Right, so this is the flip side. Terlipressin is a synthetic prodrug of vasopressin. Its main function is tied to its potent, localized vasoconstriction.
And the primary use for that is?
Acute gastrointestinal hemorrhage, specifically for bleeding esophageal varices. Severe bleeding in the throat often seen in liver disease.
And it works by clamping down on the blood supply.
By reducing mesenteric and splanchnic blood flow, terlipressin can effectively reduce the pressure in those vessels and control the hemorrhage. Crucially, studies show it improves survival rates and has a better systemic side effect profile compared to older, non-specific forms of vasopressin.
And finally, liopressin, the swine analog. Is that still used?
Liopressin is used less frequently now. It is shorter acting, typically 4 to 6 hours, and less potent than AVP. It mainly targets V1 receptor-mediated indications, like short-term treatment of post-operative ileus or sometimes for short-term management of DI.
We spent most of our time talking about saving water. But what if the body has pathology where it's conserving too much water, leading to dangerous dilution?
Yes, what then?
That's where the opposite strategy antagonists come in.
This raises an important question. What if the problem is SIADH syndrome of inappropriate ADH secretion, where the body keeps releasing AVP when it shouldn't?
Right.
This excess AVP forces the retention of pure water, diluting the sodium concentration in the blood, a condition called hyponatremia. To fix this, we need to block the V2 receptor to promote free water excretion.
So we temporarily induce a beneficial controlled form of aquaresis, which are the key agents.
The main players are tolvaptan and mozavaptan. These are orally active, non-peptide selective V2 receptor antagonists, often nicknamed vaptans.
And they just block the receptor.
They specifically block the V2 receptor on the collecting ducts, preventing AQP2 insertion and promoting the excretion of salt-free water.
What are their key clinical indications?
Their clinical use is centered around treating hyponatremia, particularly in euvolemic and hypervolemic states.
Normal and excess fluid volumes.
Right. This includes SIADH, as we mentioned, but also hyponatremia associated with chronic conditions like congestive heart failure and cirrhosis of the liver, where the body's response to low cardiac output or core liver function involves inappropriate water retention.
So they let the body get rid of the excess water?
They allow the body to excrete the excess water load and restore sodium balance.
Beyond direct agonism and antagonism, the pharmacology introduces a major paradox that challenges the rules we just established. The thiazides paradox.
Ah, yes.
Why does a diuretic cause an antidiuretic effect? This sounds completely wrong.
This is one of the most intellectually satisfying mechanisms in renal pharmacology. Thiazide diuretics paradoxically exert a significant antidiuretic effect in diabetes insipidus.
And the real kicker?
The real kicker is that they are effective even in renal DI, where the V2 receptors are broken and AVP and desmopressin are completely useless.
That makes them a vital tool in treating the kidney-based form of DI. So how does forcing salt and water out actually lead to less urine production?
The mechanism is compensatory and operates far upstream of the V2 receptor. Thiazides inhibit sodium and chloride reabsorption in the distal convoluted tubule, causing increased salt loss.
Okay.
This leads to a state of chronic, mild volume depletion and electrolyte depletion. The body interprets this as a need to save volume.
So it panics a little.
A little. To compensate, the proximal tubule, the initial part of the nephron, aggressively enhances its reabsorption of salt and water.
So it's a desperate attempt to save volume before the fluid even reaches the collecting duct.
Precisely. By aggressively enhancing proximal tubule reabsorption, significantly less solute and fluid are delivered downstream to the collecting ducts.
So there's just less fluid to pee out.
The overall volume of fluid reaching the unresponsive collecting duct is reduced so much that the total urine volume drops dramatically, reducing polyuria in both forms of DI. It's not fixing the V2 defect, it's starving the system of volume.
That's truly a mechanism of indirect systemic compensation. Are there other agents that modify endogenous AVP action?
Yes, we have drugs that enhance the effect of whatever residual AVP a person might have, which is useful in partial DI. Chlorpropamide and carbamazepine are examples.
And they make the kidney more sensitive to AVP.
They increase the antidiuretic response to AVP in the kidney, potentially by enhancing the synthesis of prostaglandins or sensitizing the V2 receptor pathway, thereby helping to reduce polyuria.
And then drugs that actually cause mild controlled DI, useful for treating SIADH.
Correct. Lithium and dimethylcycline are used to treat inappropriate ADH secretion. They act as functional AVP antagonists by partially inhibiting the action of AVP, likely by interfering with CAMP formation in the collecting duct cells.
Which makes the kidney less able to concentrate urine.
And that promotes water excretion, correcting the underlying hyponatremia.
Given that we are controlling the body's entire water budget, the margin for error must be small. What is the single most critical, life-threatening adverse effect associated with using AVP and its analogs?
The most serious risk, without a doubt, is water intoxication leading to severe hyponatremia, dangerously low plasma sodium levels.
Because you're saving pure water.
Remember, AVP forces the body to retain pure water. If too much is retained, or if the patient continues to drink excess water while on the medication, the body's sodium becomes dangerously diluted. This is why desmopressin, despite its selectivity, requires careful titration.
And the symptoms of acute severe hyponatremia are often neurological.
They are, because the brain cells swell as water rushes in to balance the osmotic gradient. Symptoms range from an initial headache and mental confusion to possible seizures.
And it can be fatal.
If the sodium level drops too quickly or too severely, it can lead to death due to cerebral edema. Monitoring blood pressure, fluid intake, and body weight is absolutely essential during the initiation of therapy to prevent this complication.
And finally, considering the potent V1 vasoconstrictive potential of native AVP and drugs like terlipressin, what are the cardiovascular red flags?
Due to its ability to increase peripheral resistance, AVP is strongly contraindicated in patients with underlying ischemic heart disease, hypertension, or chronic nephritis.
Because it can put too much strain on the heart.
Its use can precipitate significant complications, including bradycardia, severe angina, or even acute myocardial infarction due to the increased workload and potential for coronary artery constriction. The physician must always balance the need for water conservation against the risk of cardiac events.
So what does this all mean? We started with a tiny 9-amino acid peptide made deep in the brain, and we followed it all the way to the collecting ducts of the kidney. We learned that arginine vasopressin is the master switch that controls virtually every drop of water we save.
We covered the sophisticated communication, the rapid mobilization of aquaporin 2 channels, the crucial role of urea recycling, or VRUT, and the vital contribution of V1A receptors to maintain medullary hypertonicity by slowing the blood flow in the vasa recta.
And it's so much more than the kidney.
We also saw that this hormone's influence extends far beyond the kidney, regulating blood pressure, increasing gut motility, and triggering the release of critical clotting factors, factor VIII and VWF.
For you, the learner, the key takeaways are twofold. First, the division of labor between the V1 receptor for constriction and pressure and the V2 receptor for water and clotting is the blueprint for modern drug design.
Absolutely. It explains why terlipressin is used to clamp down on bleeding vessels, while desmopressin is the standard of care for conditions needing pure water conservation, like nocturnal enuresis or neurogenic DI.
Second, you must understand the distinction between the types of diabetes insipidus for correct treatment.
Neurogenic DI, a lack of AVP, is fixed with the agonist desmopressin. Renal DI, an unresponsive kidney, often requires the therapeutic paradox of thiazide diuretics or V2 pathway inhibitors like dimethylcycline.
And the big danger.
And remember, the relentless focus on retaining free water means the #1 risk in this entire class of drugs is life-threatening hyponatremia.
It is an incredibly tightly managed, complex system.
And this brings us to a final provocative thought for you to mull or explore on your own. Given that AVP is structurally a twin to oxytocin, the hormone of social bonding, and given that AVP is recognized as a key neuropeptide involved in social cognition, stress regulation via V1B, and memory tasks within the central nervous system,
Hmm.
how might future selective V1B or V2 receptor modulators, designed explicitly to cross the blood-brain barrier, be leveraged not just to fix fluid balance, but potentially to influence human social anxiety, emotional memory, or interpersonal recognition? The master water switch may also hold the keys to the master cognitive switch. Something to think about the next time you take a sip of water.